Let's unpack this. We're doing a deep dive into what I can only call a critical care nightmare.
It really is. We're talking about abdominal compartment syndrome, or ACS.
And it sounds so simple, right? Just too much pressure inside the belly. But it's this rapid life-threatening crisis where that internal pressure literally crushes the life out of organs that are nowhere near the abdomen.
Exactly. And our mission today is to understand how that pressure turns so deadly and, for you, why it creates this systemic havoc. It all starts with IAP, or intra-abdominal pressure.
Right, IAP. So normally it's what? Basically nothing?
Almost nothing, maybe 0 to 5 millimeters of mercury. ACS is when that pressure spikes and stays elevated. We're talking above 20, maybe 25 millimeters Hg, and you start seeing brand new organ failure.
And the causes are not always what you think. It's not just like a major trauma.
No, and that's a key point. You often see this after huge systemic events like sepsis or massive burns because they require massive amounts of fluid resuscitation.
So you're pouring in fluids to save someone's life.
And that huge volume makes the body, well, it starts drowning from the inside.
Yeah.
That fluid third spaces and the abdominal pressure just skyrockets.
Okay, so here's the aha moment. This elevated pressure acts like a giant internal clamp.
It's a perfect analogy. It chokes off venous and lymphatic drainage, so blood just can't get back to the heart. And it tanks what we call abdominal perfusion pressure, which is, it's what keeps the organ supplied with oxygenated blood.
And if the veins are jammed, everything backs up. Let's start with the lungs.
The diaphragm gets shoved violently upward, it compresses the lungs, and suddenly clinicians are using these frighteningly high pressures just to get any air in.
And that venous traffic jam hits the heart next.
Absolutely. The return is obstructed, so cardiac output plummets and you get hypotension. And all that back pressure is why you see this profound pitting edema. The whole body just swells.
Okay, so the kidneys make sense. They're right there. The renal veins get compressed, urine output drops, and they fail. But how on earth does pressure in the belly cause a problem in the brain?
Because it's all one big hydraulic system. The venous drainage from your brain has to eventually flow down through your chest to get back to the heart.
And the abdomen is blocking that main highway.
It's blocking the main highway, so the pressure backs up all the way into the cranium. You get increased intracranial pressure, and you risk starving the brain of oxygen.
Wow. Okay, so given that the symptoms, low blood pressure, trouble breathing, sound like a dozen other critical conditions, how do you even spot this?
You have to be looking for it. A high index of suspicion is everything. And the physical exam, it's totally unreliable. The belly might be distended, or it might not.
So there has to be a specific diagnostic tool then.
There is, and it's surprisingly simple. You measure the IAP directly, most often using a standard Foley bladder catheter that's hooked up to a pressure transducer.
And that measurement is the key to telling it apart from, say, a bowel obstruction.
For sure. A bowel obstruction you'll see on a CT scan pretty easily. But the real challenge is differentiating ACS from sepsis. Both cause multi-organ failure.
Ah, so that's the crucial distinction.
That is the ultimate filter. If the patient's organs are failing but the IAP is normal, you're likely looking at sepsis. If the organs are failing and that pressure is screaming high, that's ACS.
So you confirm it's ACS. What are the first moves?
The goal is just to get that pressure down fast. You start with non-surgical things like positioning the patient, maybe NG tubes for drainage, and you become extremely careful with any more IV fluids. But really, you're just buying time.
So those are just temporary measures. The definitive solution sounds like it would have to be pretty radical.
It is. When those things don't work, the only answer is surgical decompression. A laparotomy, where you don't close the fascia, you literally leave the abdomen open to relieve the tension.
And the prognosis is all about speed then.
It is entirely dependent on how quickly you decompress.
So to wrap this up, ACS is this terrifying example of how a very local problem pressure in one body cavity can cause a total global systemic collapse.
And it leaves you with this really profound clinical question, right? If massive fluid resuscitation is a huge risk factor, how do clinicians treating, say, a severe burn patient balance that immediate life-saving need to push fluids with the delayed but equally life-threatening risk of causing this exact pressure-induced failure?
It's a terrifying gamble, a true double-edged sword in critical care.